You're listening to Hold On a Minute, a podcast by UNFPA Asia and the Pacific. This podcast series presents inspiring and powerful stories on the sexual and reproductive health and rights of women across the Asia-Pacific region. I'm Chawarat Yongjiranon Erpupe, your host. On this episode, we address one of the most painful and damaging injuries suffered by women during childbirth, called obstetric fistula. Obstetric fistula occurs when a woman suffers a prolonged and obstructed labor without access to timely and quality maternal health care. The result is a hole between the birth canal and bladder and/or rectum. This condition leaves the woman leaking urine, feces, or both, resulting in lifelong physical and emotional trauma. Women may suffer chronic medical problems, depression, social isolation, and deepening poverty. In today's episode, we will hear from experts to understand the reasons behind obstetric fistula and what we can do to end this tragic condition. But first, let's listen to the story of Aisha.
My name is Aisha. I live with my husband's family in his village. We are surrounded by beautiful mountains. But when I was pregnant with my first child, I could not visit the doctor or a midwife because it was difficult and too expensive to travel. One day, I started to get labor pains. I was in so much pain that I could not move. My husband brought the traditional birth attendant from the village to help me deliver the baby. It was a difficult, painful, and long labor which lasted for 4 days. Despite the complications, the traditional birth attendant didn't call for professional medical help. Finally, my baby was stillborn. I was still in a lot of pain. I also started to leak urine which I could not control because of the injury I got during childbirth. I felt embarrassed and ashamed. People in my village avoided me or made fun of me. I never felt clean. My husband and I did not give up though. We kept asking around to find out who can help me. After 2 years, we heard about a hospital in the big city that helps women like me get surgeries for free. My relatives and in-laws helped us collect money so my husband and I can travel to the city. I was finally able to see a professional doctor at the hospital. The doctor said that my condition was not easy to treat. One surgery was not enough. So I had to go through multiple surgeries, which took 3 years. It was a tough process, and I had to be really patient. Thankfully, the midwife who worked at the hospital became like a sister to me. She supported me and encouraged me to stay strong. Finally, after 5 surgeries, I'm fully healed and so happy to return to my normal life. I was lucky because I was able to find a hospital which offered help for free. Without their help, I would have continued to live in shame and fear. I'm sure there are many women with the same condition who continue to suffer because they don't know they can get treatment. As a fistula survivor, I now spend time speaking to the women in our village about what happened to me. I tell them to visit a trained midwife during their pregnancy and delivery so they avoid what happened to me. I don't want any woman to go through the same pain that I did.
Hold on a minute. The story doesn't always end like this. Despite the traumatic experience of Aisha, her story is one of hope because she was eventually able to find and receive treatment and care. But she should not have had to endure this painful condition in the first place. And sadly, Aisha is not the only woman who had to suffer obstetric fistula. It is estimated that 500,000 women and girls are living with this condition. Today, we are honored to hear from 2 experts working to improve maternal health and eradicate obstetric fistula. We have with us Dr. Shersha Saeed, a prominent physician and surgeon from Pakistan and a fellow of the Royal College of Obstetrics and Gynecology in the UK. Dr. Saeed has worked passionately as an advocate for women's rights and maternal health at both national and international levels. He was the president of the Society of Obstetricians and Gynecologists of Pakistan from 2007 to 2010 and is currently the president of the International Society of Fistula Surgeons and also the Pakistan National Forum on Women's Health. Also with us is Catherine Breen Kemkong, the UNFPA Asia-Pacific Regional Advisor on Sexual and Reproductive Health and Rights. Catherine leads UNFPA's work in the Asia and the Pacific region for maternal and reproductive health and midwifery. Before her current role, Catherine also worked for UNFPA in countries across the region, such as Thailand, Cambodia, and Nepal. Prior to joining UNFPA, she worked with international NGOs in India, Thailand, and Myanmar. We heard about the story of Aisha, and I can imagine how much stress and how much of a traumatic situation it was for her during her pregnancy. Can you tell us a little bit more about her story, Catherine?
Yes, so Aisha's story is really, it's a very painful reminder for all of us of these women that are probably some of the most forgotten and the most left behind in countries all over the world. Aisha's story is typical of women who suffer this painful and really life-altering injury from the simple and natural act of giving birth. So Aisha, she was living in a remote part of the country, and that's something that's quite characteristic. We see that women who experience fistula, they're often living in the most remote parts of countries where it's really difficult to access care. And she was also unable to afford care. I think in the story we heard that they didn't have the money for her to even attend antenatal classes or the classes to help her prepare for the birth and stay healthy during her pregnancies. And I think also Aisha's story is painful as we can see that there's just this level of neglect. I mean, being in prolonged labour for so many days without anybody prioritising her care, nobody prioritising her access to this emergency care. It's really, it's one of neglect. And the other thing I think that's really sad about her story is this, and it's very characteristic of women with living with fistula, is the loss of her baby. Can you imagine? I mean, if we pause and think about it, you've gone through this long and painful labour and you end up with this horrendous lifelong injury, but you've also lost that baby that you've carried for however many months. And so all of these, pains combined make living very, very hard. And I think that story of Aisha is one that very sadly is repeated time and time again in many of the countries.
Catherine, exactly what I think a lot of us are thinking when we hear about her story, because in today's world with the technology that we have, it's sad to know that this is not just the only case. Dr. Shersha, you have been in this field for so long. I'm sure you've seen so many stories similar to this. Is there a specific story that you've come across that, you'd like to share with us? And who, in your thoughts, are the most likely to suffer from fistula during childbirth and why?
Well, you are very right. Thank you very much for giving me this chance to talk about our very unfortunate patients. And only those are fortunate who can reach to our hospital where we can treat 99% of them. The bad thing is that majority of these patients are living in the remote areas and mountains, and they don't know even that there is a hospital where services are available and they can be treated freely. So one of the examples I want to give you, one of our patient, she comes from the Rahim Yar Khan, which is a small city about 400 miles from Karachi. She was born blind, but she got married at the age of 14 years. And after just few months after that marriage, she became pregnant. And when she was 6 months pregnant, her husband died because of the accident. And after that, it was a big problem because she was thrown out from her husband's house. In fact, the in-laws thought that she brought the bad things to our home, that our son died. But anyway, she ended up with her mother, and her mother was an illiterate woman, and she organized a TBA, traditional birth attendant, to deliver her. She was in labor for 3 days, and after 3 days, she delivered a dead fetus. and she developed RVF and VVF, vaginal fistula and rectovaginal fistula. And then she has no idea where to go because her mother was angry most of the time because she was passing urine and stool at home. So she found out after knowing many people that there is a hospital in Karachi where she can be treated freely. So she decided to come to Karachi. She traveled this 400 miles in 3 days. It's just not because it is very far. It is just because no bus will take her after a few miles. They will throw her out because she's smelling and the other passengers are saying that this is very bad. Anyway, she came to Karachi, and from Karachi station she traveled to our hospital, and she was admitted in our hospital. Then she has to admit 6 months because she needed 4 operations with colostomy and everything. After 4 months, she was treated fully and everything was fine. So she used to tell us that when she was blind, people like to help her because she is blind. But when she has this fistula, nobody liked to help her. Actually, everyone was hating her. So she told me it's better to be blind than having a fistula. So this patient was an example where she can get a treatment and she's fine. Same other way, there is one patient came from Balochistan, from a very far remote village. She was in labor for 4 days actually. Then she delivered baby with same problem. 2 years she has no place to go. After some time, they came to know about this hospital, so she started journey on a small stretcher, and they brought her to big city Khuzdar, and from Khuzdar she came to our hospital. She was treated for 4 months. She was recovered. So
Doctor, I think you're going to probably answer what I was going to ask a bit in terms of. I mean, I just had to say something because 3 to 4 days of labor, that's quite a big situation there. And it seems as if there's different aspects that we have to think about. The aspect of the culture aspect where she was married at 14 years old. Another aspect that, she didn't have the facility or the experts to help her during her pregnancy. What are the factors that are in play with the causing this ongoing situation?
Very good question. I gave the example of these 2 cases because in both cases, first of all, she get married in very younger age. Both of them, 14 and 14 and a half. They were kids and they got married. And they got married with the men who are illiterate and they have no idea about the family planning or not to getting pregnant once you are in the situation. And then the worst thing was in that village, in both of their village, they have no help as far as basic obstetrical care is concerned. So they have no midwives. They only have traditional birth attendant, and they have no idea about the family planning or the normal delivery, etc., etc. So when both of them went into labor, they have no place to go because there is no BHU or RSC. BHU means Basic Health Unit or Rural Health Center. So they were under care of TBA. TBA has no idea. TBA just worked that it will happen. It will take 2 days, 3 days, 4 days. So there was no obstetrical care. And once she was in labor and there was a delay of 24 hours, she should be transferred to tertiary care center where a cesarean section can be performed. So the tertiary care center was far from the places. So then she delivered, and after delivery, in both of cases, it took more than 2 years for them to leave their village and come to the hospital where they can be treated. So it's basically poverty and illiteracy. So, and the third thing, which is very important, the absence of emergency obstetrical care. When there is no emergency obstetrical care, what can you do? And before the emergency obstetrical care, both of these girls should have been seen by a qualified, competent midwife who can refer them, who can diagnose the problem, but it's wrong and patient will go into obstructed labor and patient will develop fistula. Our trained midwife will recognize these conditions from the very beginning. and they will send the patient to tertiary care hospital. So these are the major things. Now, if you are talking end of the fistula 2030, so what is the conclusion from these two cases and many cases in different parts of the world? The conclusion is, if this girl was seen by competent, confident, skilled midwife, the midwife can book them. Midwife can decide when the delivery is imminent and is it possible for them to do the delivery, or it is good to shift patient to tertiary care center or secondary care center where they can have a cesarean section and there will be no fistula. So this is the story.
Is very, very extreme cases from what I'm hearing from your side. Now, when we take a look at other regions, the Asia Pacific specifically, there has been the prevalence of the fistula condition. But how common is it, Catherine? Because, when you talk about the Asia Pacific region, it's quite a big range of different social economic situations that we're talking about. How prevalent is it?
So it's quite hard
to actually quantify the prevalence of obstetric fistula because, as Dr. Shersher explained, it's often a very hidden illness and condition. Women that are living with a fistula, hidden in mountainous areas, in their villages and in their homes, and they're not coming out, so they're not counted. So it is quite hard for us to really quantify, but they say that there has to be at least 500,000 cases of obstetric fistula in the world. And in our region, particularly Afghanistan, Bangladesh, Pakistan and India, these are the countries where we are seeing more cases of obstetric fistula. And some of the reasons for that are also the fact that women are still having significant number of the deliveries at home. They're not coming to health facilities to deliver their babies. So this really, as Dr. Shersher explained, really contributes to the burden of obstetric fistula.
When we're taking a look at the situation and the case studies that we've talked about so far in our podcast, there's so many signs or so many factors that come into play in contributing to the prevalence of obstetric fistula. So when we talk about the prevention of it, Dr. Shersher, what are the main factors that should be considered by lawmakers and our communities to prevent this?
Number one, child marriage should be stopped. This is a cultural thing, this traditional thing, and for that they need to be educated. The village should be educated, the people should be educated. So suppose there is a girl who is under marriage and she get married, so there should be somebody like midwife who can advise them for the family planning, even if they get married in younger age group. But if there is somebody who can advise, so they can advise for family planning, and despite family planning, she become pregnant, then this somebody who is midwife should book her for a proper basic antenatal care. And once she is under care of this midwife will make sure that this patient will not go into labor in the center if she feels that she has abnormal pelvis and there is a chances that she will go into obstructed labor. So this patient should be referred to secondary or tertiary medical center where she can have normal delivery or cesarean section. And if she is delivered by the competent obstetrician and gynecologist or midwife, there is a very little chance that she will get a fistula. So this is very simple thing. And all the key is basically education and eradication of poverty. Fistula is a disease of poor people who are living in slums, who are living in rural areas where no help is available. And that is the dilemma.
Dr. Shersher, a good point in terms of the importance of the role of midwives, something that we've talked about extensively, Catherine, in our previous episode, about how it's so important to support midwives to, and it's not just about increasing the numbers, but the quality of education and training that goes into midwives. When you take specifically the role of midwives, how can they protect women from this painful injury?
Midwives are really key to stopping any new cases of fistula. midwives, they provide care to women during their pregnancy and during their birth. And they really play this critical role, as Dr. Shersha has explained, in identifying, caring for a woman during her pregnancy, but also identifying whether she's at risk and referring her early. Midwives work in partnership with obstetricians, and our focus is on that woman and her care. And it's both of our priority to make sure that she has a healthy pregnancy, birth, and an outcome of a healthy baby. So midwives are critical in this role of caring for all women, even in the most remote parts of countries where obstetricians are unable, to go. The other thing is that women really care holistically for women during their pregnancy and birth, and after their births as well. So midwives are likely to know which women have fistula. And as Dr. Shersha explained, actually talking to the women about the fact that there is care available, that there are champion, wonderful fistula surgeons in some countries who will be able to do surgery and repair this condition for women. So midwives play a big role in that, in identifying women that are suffering with an obstetric fistula and getting her the care that she really needs. And the other thing that I think is really important role of a midwife with fistula is that they can provide some of that psychological support and care, because when a woman has gone through a very traumatic labour and birth, she's likely to be quite traumatised, and the midwife is able to provide that sensitive, close care to the woman and to listen to her and hear from her if she would like to have other children after that fistula is repaired, to support her in that and build her confidence in that, or alternatively to help her with family planning and helping her make those choices of not to have a baby if it's going to be risky for her life and something that she also doesn't want. So midwives really play this crucial role of being with all women, including with women that have obstetric fistula.
When you take a look at the bigger picture, obviously, it's so crucial to support and to build that ecosystem for midwives, to thrive and to access those, far-reaching areas where, these cases are unfortunately, great in number. So when we take a look at the UNFPA and what it is doing to prevent obstetric fistula from happening, how is UNFPA treating it? How is UNFPA supporting hospitals?
So UNFPA places huge priority in midwifery, strengthening the quality of midwifery education, because we know that if we train competent midwives, confident, competent midwives, and then that they are out there deployed into these health facilities and centres and mentored and supported, that we're not going to be having these bad outcomes like obstetric fistula for women. So one of our huge efforts is on strengthening the quality of midwifery education and trying to realise a dream that every village, every woman has access to a midwife for her pregnancy and her birth. The other thing that UNFPA does is supporting the training of obstetric fistula surgeons. Dr. Shersha is the absolute expert and should talk to this, but it's really important. UNFPA places importance on training obstetric fistula surgeons, not huge numbers of them, but on quality, on a few qualified, passionate, competent fistula surgeons who can operate in centres of excellence. So we support that in a number of countries in our region. And also the equipping of some of the hospitals with some of the key equipment and things that they need to actually do the repairs. But I would say that there's a huge amount more that UNFPA could do, and our only limit is our funding.
Catherine, actually, you have been with Dr. Shersha at his hospital. And so I would like to ask Dr. Shersha about the situation on the ground in Pakistan. Obviously, we don't see everything with what's been going on in the world. So it's definitely interesting, and it would be a great insight for us for our podcast to know more about what you're doing on your side to prevent obstetric fistula, Dr. Shersha.
Okay, thank you. Just before I telling you about what I'm doing in the hospital, we must remember that whenever you have a maternal death, with one maternal death, you are going to have about 15 to 20 complications. And out of these 15 to 20 complications, not in 15 to 20, but if you have 100 maternal deaths, then you have 1500 complications. And out of these 1500 complications, maybe you will have some fistula also. So any country which is having high maternal mortality rate, they are having fistula which is not in front of us. So like in Pakistan, there is estimation that we are having about 4,000 to 5,000 new fistula formation in our country. And with all our centers, with the efforts of UNFPA, and I'm really thankful to UNFPA for last many years, they are supporting us and many organizations in the world to help women in need. So when you have this all these facilities, so we are not repairing more than 2,000 to 2,500 fistula every year, despite all our efforts. So whatever we are repairing, we should continue repairing those fistula. But at the same time, we must close the factory of the fistula formation. And that factory will only be closed by the trained, competent, confident, skilled midwife who can help those women. In Pakistan, we have more than 85,000 villages. And we and Pakistan Medical Association and Society of Obstetrics and Gynecology, they all demand by the government that we at least we need 200,000 competent midwives, so they can work in these villages. They can shift the patient to the basic health unit. They can go with the patient to tertiary care center or RSC, rural health center, where the patient can have cesarean section when it is required, and then the fistula can be prevented. In Kozhikode Women Hospital, what we do, we produce 140 very competent midwives every year. Then every year we do more than 20 competency-based workshops, CBT, and most of these workshops are sponsored by UNFPA and some other organization. And these midwives come all over the country and they stay in our hospital from 6 weeks to 12 weeks, and we overhaul them. We change their attitude, we train them, they attend labor room, and they become a very competent and confident midwife.
Well, there are other factors as well in terms of things that we can't control. There are things such as disasters that happen when you are challenged with disasters that you can't control. For example, in the Asia and Pacific area. How is the situation, Catherine? Do you see increased cases of fistula in humanitarian situations?
Yes, so Asia and the Pacific is very prone to natural disasters, and we have seen also political crises, we could say. So in countries like Afghanistan, where women are really restricted in being able to seek care during their pregnancy and birth, it's highly likely that we are going to be seeing increased cases of fistula, of obstructed labour, where a woman didn't get the care that she needed. We also know that in other countries in the Asia-Pacific region that experience natural disasters, the health facilities are destroyed, the roads are broken and transport isn't available. So this really limits women's ability to access care. And this is exactly the type of situation that contributes to women suffering a fistula, because she hasn't been able to seek care. She's probably experienced a prolonged labour at home without the care that she needs. And it's highly likely that we've got many cases of fistula in these situations. Now, the thing is that we try to find out about those. We try to do some education of our midwives in these different countries to be able to identify, notify and refer. But I think one of the things that we have to just do better is ensuring that when we know that these sort of natural disasters are going to take place frequently, and we need to be prepared for that. And we need to be prepared to have midwives and effective referral systems ready to go when disasters happen, so that women are not alone during their pregnancy and birth, and that they receive the care that they need so that they don't end up with these horrific injuries in childbirth.
Now, throughout our conversation, we've talked about a very serious situation that is still sadly ongoing. There are a lot of points to consider, but at the end of our podcast, we really do want to send a significant, important message to our listeners. So, Dr. Shersha, can you give us any final thoughts on how we can end this painful illness?
So my message is very simple, and message towards the policymakers of different countries, especially like Pakistan. If we want to end fistula till 2030, we have to do massive investment in the midwife, number one. And when we give this massive investment in the midwife, we'll hope that this midwife will not only work as a midwife, but also she will work as a community developer or the community supporting staff. And it is the most easiest and most cheapest way to prevent maternal death and prevent genital tract fistula.
Catherine, coming from a perspective that has been working in the Asia Pacific region, what are your final thoughts about how we can end this painful illness?
So for me, ending obstetric fistula is a problem that has a solution. And that is something that's very powerful, because there's many problems in our world that don't have a solution. And this problem has a solution. And we've talked in this podcast together about what those solutions are. So midwifery, investing in midwives, investing in quality education of midwives and deployment and supporting midwives, really across all countries. This is the big first step for us in preventing and ending obstetric fistula. And the second area that I still feel is so important is that every woman that's living with a fistula, that we reach her, that we find her, and that we treat her. It feels like it's something that's manageable and something that we should be able to do in our lifetime.
Catherine, Dr. Shersha, listening to you has made me emotional. It has. It is because it's as we said, it can be solved. We just need to make the right moves. Thank you so much for your work. Dr. Shersha, thank you so much for joining us here on our program. We look forward to hearing from you and Catherine as well in terms of how your work will proceed and continue on with the fight. Thank you. Thank you also to our listeners for joining us today. For more insightful episodes of Hold On a Minute by UNFPA Asia Pacific, follow our podcast pages on Spotify, Facebook, YouTube, and Apple Podcast. Just search for UNFPA Hold On a Minute. See you in our next episode.